so I'm going to jump in here to this ILCOR evidence-based research. So the objectives here is we're going to understand what ILCOR's role is in guideline development. We're going to talk about the major 2025 updates to ACLS, PALS, and BLS. We're going to compare them to the 2020 and then discuss potential field implications for EMS providers. So first and foremost, what is ILCOR? So ILCOR, it's a mnemonic, and it's the International Liaison Committee on Resuscitation. This is a group of resuscitation experts. This committee was formed in 1992, and they recommend evidence-based guidelines to a bunch of different players, and you can see some of those players on your screen there. The one that affects us the most is the American Heart Association. They also provide, through their group of resuscitation experts, information to the European Resuscitation Council, the Australian and New Zealand Committee on Resuscitation. So those individuals can take or leave what ILCOR is sending them, right? They can say, and I'll just use it as an example, hydroxycobalamin for cyanide poisoning. It may come from ILCOR that says, we believe that this is really beneficial, and Europe may go, okay, well, then we'll adopt it, and the United States may go, we're not quite there yet. We want some more research done. So it is up to these institutions like the AHA and the European Resuscitation Council to ultimately implement it within their guidelines, but the information is coming from ILCOR, all right? So this helps to shape all of these national guidelines like the American Heart Association and the lettered courses that you all are familiar and certified through. So a summary of the updated process here. They have systematic reviews, evidence updates, scoping reviews, etc. Then there's an opportunity for a public comment period. They focus on the new science in 2020. And then there is an emphasis on patient-centered outcomes. They're looking at survival and neuro outcomes to help drive what their recommendations are going to be moving forward. So the reason that they look at focus on the new science from 2020 is if we've been doing epinephrine for the last 50 years, it's probably not caused a ton of harm. It may not be a huge benefit, but they want to look at what we just recently changed 5 years ago. Was it impactful? Was it not? And should we make a change based on that information? And that's kind of the driving force. So we can get through these pretty quickly. Before I do this, though, I want to make sure you are very understanding and I am very clear in my communication. These are not adopted at this point. This is simply a recommendation from ILCOR to the American Heart Association. I have no reason to doubt that the American Heart Association will adopt them, but do not follow what I am getting ready to tell you until it is in your proper protocol or at least in your standards for American Heart Association, ACLS, PALS, and CPR guidelines. All right, so CPR, dispatch-assisted CPR, it continues to be highly emphasized. That's not going to go away or not change. Guidance with chest compression only CPR is one of the things that they're going to continue to look at here. AED use and accessibility. So avoid locked AED cabinets due to delayed access, and you may be familiar with those in certain applications or settings. You go to get the AED and you try to open the cabinet and it's locked. So the recommendation is going to be that none of these AED cabinets are locked. We should maybe alarm them, but not lock them. AED retrieval delays negatively affect survival. We know that that is true. If they're in VFib or pulseless VTAC, we want to get them hooked up and defibrillated as quickly as we can. They are looking at drone AED delivery. So again, this is kind of an interesting and on the forward cusp of what we are looking at trying to do, I guess, in long term. It's promising, but it is not yet going to be recommended because they still have some things that they need to work out. The evidence at this point is mostly based on simulation. They haven't necessarily, at least to my knowledge, and based on the information that was sent to me by Brandon with this update, they have not really done a lot of field studies, although I will tell you that even where Brandon is working currently, they're doing drone delivery for pharmacology and medications directly from the pharmacy to the patient's front door. So a lot of this is going to start to emerge over the next couple of years. I'm pretty confident in that. But drone AED delivery is one of the things that they are looking at. Still in the early stages of integration, so they don't really have at this point the ability to say, yep, this is a true recommendation. But essentially, if you think about it, a lot of people have the different applications on their phone, Pulse Point or something like that. So we already know, I'm at Kroger, I'm at Walmart, and all of a sudden somebody at Walmart's having a cardiac arrest event. There's already information out there that will send that to my phone and tell me, hey, you're in the area and somebody's having a cardiac arrest event. If you kind of think about it as the same thing, and these drones can deliver AEDs directly to the scene so that somebody can use it. It's kind of interesting and something to think about. CPR and drowning, emphasis is going to be on early rescue breathing for drowning victims. Makes sense. Not huge changes, but again, there's some kind of a reason based on the evidence and the meta-analysis that they have been looking at as to why they're going to emphasize that. Performance and quality. So feedback devices, real-time compression and monitoring feedback is encouraged so that we know if our compressions are doing well. And I think you'll find here as we talk about the mechanical CPR devices, it's kind of interesting based on this feedback device, because I'll just be the first one to tell you, I think that a mechanical CPR device like a Lucas or one of those types of machines is going to be able to do CPR much more effectively than I can, at least for a long period of time. But we'll get there when we get there. Heads up CPR, not recommended currently as routine practice. They have been looking at this for about the last 5 years. This actually came out of Asia, where the elevators were too small, and you probably run into that in some of your buildings. So you go to put a patient in the elevator that is in cardiac arrest, and what your findings are is the elevator is too small, so now you have to try to break down the cot and set the patient up and do all of those things that we've all encountered at some point in time. Over in Asia, what they found, and this is probably 10 years ago, is they had a lot of these different elevators that were too small, so they were putting the patient's head up to try to get them to just simply fit into the elevator. And when they were doing that under cardiac arrest and CPR, they were finding that the survival outcomes were actually improving. So that is where the head-up CPR is coming from. The research is ongoing, and like I said, they have been talking about this for at least the last 6 to 8 years, and maybe even a little bit longer than that. Compression duration and pauses. So they're recommending that continue pausing every 2 minutes for a rhythm check. And the cycle lengths of 1, 2, and 3 minutes are still under review. So for the time being, they're still going to do 2 minutes of CPR and then reevaluate your patient, but understand that could go to 1, could stay at 2, or it could go to 3 minutes. They are reviewing all of those. Under ACLS, CPR and defibrillation, and this is where I'm talking about the Lucas device or the other one from Zoll, the Zoll Auto Pulse, just to be fair and not point out one versus the other. But the mechanical CPR devices, and I vehemently disagree with this, but this is the evidence. There is no benefit versus manual CPR for neuro outcome or survival. I personally disagree with that just because, and I've probably talked about this, after we ended up getting the device where I used to work, we ended up getting a second device, and all of a sudden people started showing up and ringing the bell and saying, hey, I was in cardiac arrest and you guys took care of me. I know that I have pictures of patients that showed up at the firehouse to thank us, and I did not ever have pictures of people showing up to thank us before we ended up putting this mechanical device into play. So it's the only thing that changed. So based on that information, I'm going to continue to say that the mechanical devices are beneficial. It is certainly beneficial for your back, and it's not going to be as tiring. But according to the evidence, there's not any benefit over neuro outcomes or survivability. So still not recommended for routine use, but they do agree that there's not enough data to support, and it can be used if manual CPR is going to be impractical or unsafe. And I think most everybody in today's world is already using the mechanical device, so they're not saying that you can't. They're just saying they don't really know how beneficial it is going to be. Consciousness during CPR. So this was a new one to me. There's been no new data since 2021. I don't know how I feel about this, and to be totally honest, I'm not very well read on it. But they are recommending that you could give small doses of sedation if the patient is awake during CPR. I'm not exactly sure how that works. I will promise you that I will be reading up on this to determine where they are going with this information. But it's always been my understanding that if they're awake, then we probably should not be doing CPR. But again, there's evidence out there to suggest this information, and these people are a lot smarter than I am. So I will be looking into this. I'll be reading, and we'll give you some information in, the coming months. Under those patients, though, they do recommend that we avoid neuromuscular blockers alone, and that makes sense. If you're able, have the ability through licensure or advanced care paramedic that you can give neuromuscular blockades, and you should also always give sedation with that. We don't ever want to just paralyze somebody and they're still awake and they know what is going on. So that does make sense. The double sequential defibrillation, you're probably familiar with this. This was talked about in the last update. It can be considered after 3 failed shocks in refractory VFib or pulseless VTAC. The evidence remains low, but what they are recommending is if you're going to do this double sequential, that we do not delay high quality CPR. So it sounds like they are going to consider allowing the double sequential defibrillation. And essentially, if you're not familiar with this is 2 different machines. They hook up and they do the shock using 2 machines simultaneously. That is what they're referring to here as far as double sequential. Airway and ventilation, advanced airway management, no new evidence or changes since the 2019, which is really the 2020 guidelines. The supraglottic airway or endotracheal intubation are both still acceptable. You can use the methods with the highest local success rate. So if you're better at doing intubations in your particular area geographically, then stick with intubation. If your particular agency is better off doing the supraglottic, then you can do the supraglottic as well. Emergency crike, it still remains a good practice option if all other airway methods fail. And remember, anytime we're going to do a crike, it should be a can't intubate and can't ventilate situation. As long as you're able to ventilate them and get their chest horizon fall, there is absolutely no reason to do a crike. Post-ROSC, oxygen and CO2 targets. We're going to start with 100% oxygen and then titrate to 94 to 98%. Remember, the reason we don't want it over that 98 is the release of oxygen-free radicals, which can cause further problems long term. We should avoid hypoxemia and hyperoxemia, and therefore we should be aiming for normocapnia, which is an end-tidal CO2 of between 35 and 45. So not a huge change in any of that. IV versus IO access. IV is the preferred first. If you can't get it within the first couple of attempts, then you can go to an IO. But the IO is associated with a lower sustained return of spontaneous circulation. So you may get it back, but they probably won't keep it, is at least the findings looking at the IO versus the IV. Vasopressors, epinephrine remains the standard, so that's not going to change, it doesn't seem. No benefit from vasopressin or vasopressin plus epi. The timing is give early for non-shockable rhythms and after the first shock for shockable rhythms. So if they're in VFib or VTAC, pulseless VTAC, then we would shock them and then give epinephrine. If it is PEA or asystole, then we would think about giving the epinephrine before we would do anything else because it is a non-shockable rhythm. As far as your circulation and medications, buffering agents, sodium bicarb, not recommended for routine use. I had a partner of mine years ago. He would always argue with me that if you gave sodium bicarb, they would come back and that should be our first line medication. There's probably some truth to the fact that we got them back. But if you remember, they're acidotic after they've been down a long period of time and we give them sodium bicarb. Now we have made them very alkalotic and there's no way to treat the alkalosis. So that is the problem, and therefore it is not recommended for routine use. We should consider it, however, in those patients that have hyperkalemia, like we just talked about. Elevated potassiums over 5.5. Certainly, if you see a sine wave, you may think of sodium bicarb, something along those lines. or in your patients that have a tricyclic antidepressant overdose. And we would know that because the QRS starts to widen by 50%. So same concept. Calcium, not routinely recommended. No survival or neuro benefit with calcium, and it can be harmful without a clear indication as to why we should be using it. So we're not probably going to be routinely using calcium anytime soon. In special situations, the hyperkalemia treatment, if they're in a non-arrest situation, insulin and glucose, which we're not necessarily going to have the ability to do the insulin part of that, and then beta agonists are recommended. If they are in an arrest, same treatment is suggested. Bicarbon calcium do have unclear benefits. If it is an opioid related, or you suspect that it's an opioid related, and think about these as being our H's and T's, naloxone is fine to give. It's just not prioritized over the CPR and ACLS. The focus should really remain on high quality BLS care. Obviously, if you have an airway, and the patient is getting proper ventilations, even in an opioid-related overdose, you don't really have to wake them up. The overdose will wear off in time. You just got to make sure that their airway is protected and they are breathing. So same concept. Point-of-care ultrasound, not recommended for routine use during CPR. It could be helpful if you're able to do it without interruptions during compressions and by trained personnel. I will tell you that some of our folks just went through an ultrasound course, and there's some push to try to look at doing some ultrasound things in the field. And there are some agencies here in the tri-state area that are already doing it with pretty good success. So I think that is another thing that will be forthcoming here pretty soon. Hemodynamic and vasopressor post-ROSC, norepinephrine is preferred over epinephrine, which is kind of interesting. So norepinephrine kind of fell out of favor years ago. But if we're thinking about, this is not necessarily for cardiac arrest and like your first-line drug, right? These are patients that we have gotten ROSC on, and we're trying to keep their pressure or their mean arterial pressure equal to or greater than 65. They think that norepinephrine is going to be better over epinephrine, and that's really not a new thing. Targeted temperature management, avoid fever and try to get them to within a normothermic or even a little bit hypothermic, so 36 to 37.5 degrees Celsius. And then neuroprognostication. So what is their prognosis going to be neurologically? They're going to delay this, or the recommendation is to delay it to greater than 72 hours after ROSC to truly see how this patient is going to end up doing. And that is going to be based on multiple modalities in the hospital setting, an EEG, a neuro exam, other imaging, etc. So EMS takeaways as far as ACLS is concerned, we're going to focus on early defibrillation, quality CPR, and proper medication use. We should know when to use devices and or medications like IO, calcium, sodium bicarb, and then use good judgment in your post-resuscitation care when you are transporting your patients. I will jump directly into PALS. You will see a lot of these are going to be pretty similar. So intra-arrest updates, ABC versus the CAB. Remember, the CAB was your circulation, airway, and breathing. So in 2020, they emphasized the CAB both based on adult data. In 2025, there's really no preference. Both A, B, and C and CAB are acceptable. So probably what most people will do is just go back to airway, breathing, circulation because it's probably easier to remember it that way. So airway management, bag mask ventilation is preferred over advanced airways in out-of-hospital cardiac arrest. Intubation only if in a highly successful situation with minimal interruption. So practice makes perfect here. Bag mask ventilations, they've been pushing this for a very long period of time. Even when I went through paramedic school 25 years ago, it was, we don't really know that pre-hospital providers should be intubating patients, just do bag valve assisting. I always kind of argue that point just from a vomitus and an aspiration standpoint. But certainly, the recommendations will allow you to just do bag mask ventilations and not really even use advanced airways in the pre-hospital setting. So whatever your protocol medical directors say, obviously you'll have some backing based on ILCOR and AHA. Ventilation rates, not specific for the pediatric patient. but they do recommend that we use age-appropriate rates and avoid hyper and hypoventilation. So based on your patient's age is what we should be guiding our ventilations to. Defibrillation, the 2 to 4 joules per kilo, and then the higher doses up to 10 joules per kilo is still going to be supported. The single versus stack shocks, we're going to do the single shocks, the stack shocks, and what we did years ago when I went through, I'll use an adult, for example. We would do 300 and then immediately charge to 300 and then go to 360. So it was 2, 3, and 360, and they were done sequential, boom, boom, boom. And we got away from that. And what you all probably know now is just doing the single shock. So that is what that is recommending here, is we'll just stay with the single and not do the stack shocks like they used to do years ago. Pad size and placement, anterior posterior placement is always going to be preferred. It's going to be preferred in the adult population as well. If you can do AP pad placement, you're going to end up probably getting a better result with your defibrillation or with your cardiac pacing, etc. But they do still recommend that you use the manufacturer's guidelines for AED pads. Vasopressor and epinephrine timing. Early epi is still important. Remember, we're talking about PALS. Epinephrine is always going to be the first-line medication in pediatrics, just because some of the other things as far as the bradyarrhythmias, atropine is just not going to be effective because it's not a vagolytic issue. If they have a heart rate that is bradycardic, then remember, in pediatrics, we still need to be doing external compressions if they are bradycardic despite oxygenation. So kind of do that inverted pyramid like you learned with your neonatal resuscitation. Give them a little bit of blow-by, give them some positive pressure ventilation. If they're still going to be bradycardic after that, then we need to think about external compressions. Sodium bicarb calcium, not routinely recommended unless they have the things that they did in the adult population, like hyperkalemia or a tricyclic antidepressant overdose. In special situations like LVADs, chest compression should not be delayed in suspected arrest. This has gone back and forth too. That, if they had an LVAD, you couldn't do chest compression. So now they're saying, yep, chest compression should not be delayed. If you suspect that they have a cardiac arrest, even if they have an LVAD, and then restarting a device can happen in parallel if multiple rescues are present. So there is obviously going to have to be additional information based on the type of LVAD that they have and how that would work. Pulmonary hypertension, we should avoid acidosis, hypoxia, and agitation, and consider ECMO early in crisis. I'm not aware of anybody doing ECMO here very locally, but I do know that ECMO is being done in the pre-hospital setting throughout the country, and that's extracorporeal membrane oxygenation, if you're not familiar with that. So again, if you truly stop and look at where we're at as a region in comparison to the U.S. and certainly globally, we are kind of behind the times in some of these things. Post-arrest care, oxygenation, and CO2 management. Same as the adult, we want to avoid the hyperoxia. We want to try to get them normocapnic at 35 to 45. Blood pressure targets, we should maintain an adequate mean arterial pressure. Remember, anything less than 65 is going to be problematic. Exact values not defined in EMS, but we should really avoid hypertension. And then the neuro prognostication, similar to what it is in the adult, based on imaging, EEG, and clinical exam, but only after about 72 hours. And that is not going to be an EMS function, but it is important for us to understand it, that we deliver this patient and we got ROSC on them. They're really not going to tell us or the family what the results or the prognosis is going to be until they've been out of their arrest situation for greater than 72 hours. So the takeaways from that portion: when to intubate and when not to. Emphasize CPR and timing, and then the pediatric airway or pediatric CPR, airway and compressions matter. We know that to be the case. So aggressive airway management and chest compressions, especially in cardiac arrest, but certainly in bradycardic situations as well. is going to be important in the new guidelines. So at the end of the day, not sweeping changes. We're not replacing one medication with another medication, but hopefully you guys have a better understanding now of all of the work that has been done over the last 5 years. It's really these recommendations that they end up coming to, and that is based on those levels of evidence and the class of recommendations so that they can support and say that what we are referring and recommending that you all do is not going to be detrimental to your patient.